Hi, I'm Mina Malik Hussain and you're watching The Coffee Table. And as always, we have a fascinating show lined up for you today. Today we're going to be talking about public health and public policy and how one informs the other. We're also going to be talking about healthcare budgets and why we need more money and how that money can be allocated in efficient ways. So, it's a little bit of everything. I'm delighted to be welcoming back on set our great friend, Dr. Naeem Zafar, who has recently received the President of Pakistan Community Award from the Pediatrics Association. Yes, it's so nice to have someone on the sofa to reinforce things. Dr. Naeem is also the president of Pehchan, which is a children's rights organization. He is the head of the Children's Rights Department at the University of Lahore and is the co-chair for Punjab for the National Action Coordination Group for a SARC initiative that works against ending violence against children. And joining me across the internet is Dr. Waheed Altaf, who is a public health and preventive medicine physician. She's been certified by the American Board of Public Health and currently is a professor of practice of public health at Lahore University of Management Sciences, where she is also the director of their health and safety program. Dr. Altaf is also the author of the book So Much Aid, So Little Development, Stories from Pakistan. Welcome to the show.
Thank you very much.
It's lovely to have you and Dr. Altaf from, across the airwaves. So, Dr. Altaf, I want to sort of start with what might seem like a very basic question, but what does it mean to, or I suppose, why do some countries receive international aid from other countries?
Well, thank you very much for the opportunity to be on your show. To answer your question that why do countries need aid, this model of assistance to developing countries actually started soon after the Second World War, when, after the colonial system broke down and countries became independent. It was discovered that a lot of countries in Asia and Africa did not have the resources to provide adequate services to their population. So those services were in health, education, water, and sanitation. So that is when this model was put into place, and it has been going on for the past 70 years now.
Yes. So when a country is given aid, does that aid come with certain expectations of usage?
Oh yes, certainly. The way that countries receive this development assistance happens in two forms. One is outright grants, which means that developing countries or funds that are made available for that purposes are just given as a grant to particular countries. For example, USAID and United States government and UK government gives grants to improve their health and education services or sanitation services.
Yeah.
That is a pot of money that is to be used for that, and you don't have to give it back. Then there are multilateral aid agencies such as the World Bank and ADB that give the countries loans at very reasonable and generous rates, which the country has to return. And but still, they are provided under such conditions that most of the countries can utilize that effectively. So these are the two mechanisms by which donor assistance or development assistance is brought into the developing countries.
Okay, I think that really sort of clarifies some sort of basic things. So, Dr. Zafar, because in your work as a pediatrician and as a community pediatrician, how important do you feel like in the sort of I know that there are social indicators for a country, and in Pakistan, maternal health and children's health is a very big indicator of how the health of the population generally also. So what is the sort of situation?
Let me start by narrating a story. When we are talking of the COVID vaccine, we are expected to receive that through the Gavi.
Right.
So that's how it goes. So unfortunately, even for the most essential healthcare initiative that we have, and remember that vaccination is the second most economical and most effective way of preventing childhood diseases and death apart from water.
Absolutely. So, Dr. Altaf, and I'm sort of now asking you a series of really basic sounding questions, but this is more for like the benefit of the audience to help us sort of better understand that how is public policy important in addressing issues such as the one that Dr. Naeem has just mentioned is that there are certain needs and urgent needs, but there's clearly a gap between the sort of state apparatus and addressing those needs, in spite of the fact that organizations like USAID or Gavi are willing to provide help.
You know, you have raised a very important issue, but issue that is very packed and needs a lot of unpacking, and maybe this is not the place to do it. But let me just attempt to say this, that, to some extent, I agree with Dr. Naeem that there is no national priority to prioritize public health and preventive health issues like vaccination. The reason I will disagree is that, if you ask any government representative, and I've been doing that for the past 40 years, they always say that, this is our national priority. And it is true, because if you look at any national health policy that has come out over any government over the past 30 to 40 years, every government says that health and well-being of its mothers and children is our priority.
Yes.
Even the present government, you will recall that if you go back to the first maiden speech the Prime Minister Imran Khan made when his government was elected, 50% of his speech was focused on maternal health, child health, stunting, and malnutrition in children. So it's not that they don't think that's important. They do think that's important. They make that their big policy initiative. The budget and money is necessary, a very necessary element of the service delivery system. It's a necessary element, but it's not sufficient by itself. I'll give you an example. I don't know about this financial year, 2020. I haven't looked at the data. But if you look at the data of the past 10 financial years, every year the health budget is underspent. So that underspent means that meager enough as the health budget is, if we come into January, February, and March, and then still there is only 30% or 25 or 40% of the budget that is spent. A large chunk of the budget is just pushed out of the door in the last 2 or 3 months. On the one hand, it is true that the country and the government of Pakistan is a resource-constrained government, and it's a poor country.
Yes.
It doesn't have enough money to fix all its problems, which is why international assistance comes in.
Yes.
But using international assistance effectively, there has to be fundamental infrastructure and a plan, which has to be the government's own plan, because they know their own problems.
Absolutely.
So if they don't make a plan and the money just comes in as a delay, it will be wasted. So that is what has been happening.
Yes, I think that Dr. Altaf, you're absolutely right, and you've really sort of cut to the heart of the matter, is that even with an existing budget, the money needs to be, somehow there's a bottleneck, and that's an infrastructural problem that clearly can be addressed. And I'm very curious to find out how, and we're going to find out after this very quick break. Stay with us. Hi, welcome back to the coffee table. We're in conversation with Dr. Samina Waheed Altaf and Dr. Naeem Zafar about public policy and specifically healthcare in Pakistan, which I feel is a super important issue, to put it very colloquially. So before the break, Dr. Naeem, we were talking about how even when we do have a budget, it's somehow the money isn't sort of used throughout the year in a kind of concentrated or focused way. I mean, at least that's how it's sort of sounding to me, a layperson. And we do have a Ministry of Health as well. So we do have this sort of infrastructure, but there seems to be kind of, gaps in the system, or sort of,
I think,
what's going on?
There are two major issues. One, that we need larger budgets. And the health receives just about 1%. So we are always trying to increase that amount, but it doesn't go beyond 1% of the GDP. Second is, as Dr. Altaf pointed out, its allocation and its usage. Now, there are always going to be gaps. The gaps start at the beginning. Where are you putting your money? Let me explain.
Yes. primary, secondary, and tertiary
primary
healthcare.
health. When we are talking about primary healthcare, we are talking about low-cost interventions in the community. Safe water, vaccination, breastfeeding,
Sanitation.
growth monitoring, infant feeding. That's what we're talking about.
Yep.
And then in the primary healthcare centers, when we are talking about tertiary health, we are talking about larger hospitals, teaching hospitals. We're talking about dialysis machines. We are talking about transplants. Now, they are costly affair.
Yes.
They save lives. Of course they save
Yes.
lives, but they save fewer lives as compared to the money spent.
Oh, okay. So we're saying that, for example, a lot of money is spent on ultrasound machines, for example.
For example, transplant. A transplant would cost you in millions and will save one life. Whereas that would save probably thousands of lives, if not more, if it is spent on clean water, if it is spent on vaccination, if it is spent on breastfeeding initiatives, infant feeding.
Which is sort of primary level,
So
really
these are
kind
low-cost
of basic interventions.
As it has always been said, prevention is better than cure.
Yes. Even if an organization like Gavi gives us vaccines, there has to be a setup by which you can access that primary healthcare pool. And I'm not, does one exist? Like, Dr. Altaf, could you weigh in on this?
Two or three things are very important, and we need to look behind those. You know, one of the things is that these low-cost interventions, like breastfeeding and childhood nutrition and all of those things have been shown over the past many decades in many countries that they are very effective in improving the health of the citizens. The question that we need to ask is that why is it that there is no investment in that?
Yes.
That's the question that needs to be asked.
Yes.
Because there is science behind it, there's research behind it, there is advocacy behind it, there's everything behind it. And clinicians, the doctors, pediatricians are behind it. So the question to ask is why?
Yes.
But let's not answer that now because that's a very large question and put it aside for a minute. The other thing is that this organization of the health system in primary, secondary, and tertiary has been tried for almost now 30-35 years in different countries, including in Pakistan. And in my opinion, that this has not worked well in Pakistan, and it's not likely to work well in Pakistan. The reason is that this system is a much more sophisticated system. It works well in those countries which have a well-developed infrastructure, which have a level of economic development, where the diseases can be filtered out well, and where the population has a high level of literacy and can take charge and control of their own health. I have seen it work very well in many countries, and it does not work well in Pakistan. The third thing I think is very important for the information of your public is, and that point also Dr. Naeem raised, and kudos to him for doing that, because usually clinicians don't raise that point, and Dr. Naeem did, is the issue of sanitation. You know, the health reforms that started in UK in the late 19th century, this was about 1800 something, were spearheaded by sanitation reforms. And those sanitation reforms were led by doctors. Because this is the famous, Dr. Naeem must be familiar with that public health experiment, the Broad Street pump, which was causing cholera in children in a particular locality in London slum. And the doctors refused to treat those children. They said, we are sick and tired of treating these children who drink this dirty water and come infected. So there has to be sanitation reform. So that was a sanitation reform that then led to health system reform. Similar thing happened in the United States in the early 20th century, in 1910, 1915, when there were these large populations that were living in tenement housing and there were large amount of immigrants coming and living in crowded places. There were sanitation reforms that led to health reform. So, just making hospitals and putting in more doctors and putting in more nurses and putting in more machines and putting in more surgeries, we have done that. Pakistan has done that over the past 20 years.
Yeah.
Doctors are now being produced at a rate which is even difficult to count. The medical colleges are sprouting around like little mom and pop tea stores around every street. But you see the health indicators of the health system. But the fact is, Pakistan has one of the most fantastic and one of the best laid health networks in the country. There are these rural health centers, there are basic health centers, there are dispensaries, there are tehsil hospitals. Money is important. 1% budget is not very high, but the United States spends 17% budget on its services, and yet it has a lot of problems. Those are also organizational and system design problems. So I really don't focus on the budget on the first round. I feel that we need to actually look at the design of and the organization of the service delivery system.
So the point that raised about how the primary, secondary, and tertiary classification doesn't work for a population like ours, do you sort of have a suggestion about an alternative approach that would work? Something that could be sort of examined as a replacement or as a more effective approach?
Absolutely. I do, but that's my own. And I usually, as a public health physician, I usually feel that these kind of recommendations should not come from one person, because public health systems involve a lot of different organizations and different institutions. And these kind of design systems should not come from the top, from authoritarian people, who say, aise hona chahiye or aise hona chahiye. These systems should be built from the base, from the grassroots, because it is those people who are going to implement them. Like most people who work in some place and they learn how to solve problems, they have experience of working there, they know how to solve problems. So this methodology of formulation is really not serving the government well. The government needs to bring in stakeholders, and it needs to bring in people who have experience of the objective reality of this country.
Absolutely.
They have experience of the health-seeking behavior of the country. They need to bring them to the table, and jointly we need to then. I can write, I have already put in public domain, I write for the newspaper Dawn, and I have written what the system should look like, what the vaccination system should look like, what the maternal health system should look like. But that doesn't solve the problem. The problem is solved if everybody gets together, because P&D department, the finance department, the education department, the local this department, the that department, the monitoring department, everybody has to get together to formulate a policy, because everybody has a piece of it.
Absolutely. And I think it's really important to consider stakeholders and that success.
Exactly. And I'll tell you a good example here as well. We definitely need to involve the associations of specialists, because if a pediatrician, in almost every meeting of the government, a pediatrician is invited.
Yes.
The EPI started off with a very good program of typhoid conjugate vaccination for the first time, because there was a very, very high rate of extended drug resistance of typhoid in the province of Sindh and in Punjab as well.
Punjab also.
So they started out, and they shook hands with the Pakistan Pediatric Association Sindh branch. And the results were amazing. The vaccination rate coverage was very high, and the incidence was brought down to 20% of the previous regime.
That's amazing.
And this time round, we could not do that in Punjab last year. We are going to do it next year in 2021. And again, Pediatric Association of Punjab has voluntarily gone to the EPI and asked them, we want to join hands with you, because we have seen it work in Sindh. We want to do it in Punjab as well.
And like Dr. Altaf said, that the people who are kind of in the trenches, as it were, are the people who know exactly what is required on the ground to make an initiative like that effective. So then policy isn't prescriptive coming from the top down, but it's people who are like all hands on deck, really.
Even in our Pediatric Association of Punjab, we have a president once from Lahore and once from out of Lahore. The purpose is that we go to districts. We go to all the districts. The current president is from Sialkot, let's say. So, and we are bent upon deinstitutionalizing it. We are taking it to the periphery, and we are going to ask every district of Punjab to chip in and to do their bit.
So that everybody has a sort of a sense, and again, like Dr. Altaf said, stakeholders, everybody feels like they are part of the solution. And they really are.
And they are. And it has been shown. Whenever they are given a chance, it has been shown.
But do you also feel, Dr. Naeem, that the sort of medical practice generally is not as community-based as it was before? Or this is just not true?
It has always been like that. It is always there is charm in clinical practice.
Yeah.
If I see a dying patient, I treat him and the patient revives, it gives me an immediate reward.
Of course.
Plus, obviously, it is more rewarding in terms of cash as well. In the preventive pediatrics, it is not like that. The results are going to come in years after you have served. So, and it doesn't make, it is not challenging as such.
Quite right. It's a sort of long-term kind of practice.
Let me talk about child rights. We have been working on child rights for the last 20 years. And after 20 to 30 years, this time we have a national commission on the child rights.
It always just really boiled down to money. We're going to take a very quick break at this juncture. Stay with us. Welcome back to the coffee table. We're talking to Dr. Naeem Zafar and Dr. Samina Waheed Altaf about public policy and healthcare. And I always find these academic conversations extremely stimulating. So, Dr. Altaf, I want to ask that the delivery of our health services is also a mixed bag. So, some of it is dependent on government infrastructure, some of it is coming through private, facilities, and there's philanthropic organizations. So it's all a kind of sort of everyone's pitching in their own ways, but then it's also a pretty unregulated system of delivery also. So do you think that also impairs the effectiveness of the sort of the care that's being provided?
Yes, again, a very good question. This is absolutely critical. That you do see this mixed bag, and the almost 60 to 70% of the health services are actually provided by the private sector. Facing up to this, that who is ultimately responsible for providing health services? It is, and in my view, I think, and all over the world, wherever you look in other countries, it is the government's responsibility. Because only the government can deal with such large numbers. So
yes.
It is part of the responsibility of the government. But government, a lot of governments do that. United States government also did that they say, well, we are responsible, but we are not going to be direct service providers. So the Pakistan government can also do that, and it does that in many ways, that it says, well, we should arrange for services to be provided by private providers. But that does not mean that the government's responsibility of regulation, of oversight, of funding, of evaluation, of quality assurance, of curriculum development, of training of physicians, of training of nurses, all of that still remains government's responsibility. The government has to certify the doctors, the government has to register the doctors. The government has a very large role to play. Yes. So that is why this whole thing of regulation and responsibility and accountability is very important.
Absolutely.
We have to have our own indigenous solutions. We're not going to look at the US model or the UK model or whatever model, because our situation is very different from them.
Yes.
Our health spending will be very different from them. So we can...
And our health priorities are also different.
Of course, we should be looking at the third world countries and looking at better models from there, and we can learn from there. Yeah. But we have to have our own models. And we have to include all our strata. And especially, I would say, we always forget the religious leaders. Yes. We always forget the teachers. We always forget the local opinion leaders. They have to be involved in our strategy planning.
Actually, that's really interesting. And that's something I, as a layperson, didn't consider in terms of when we're looking at, because essentially healthcare is working with the community, and those are all different people that are part of that same kind of, ecosystem. And do you think that this is also where public awareness is, or awareness building is also a useful strategy?
Of course, that has, building awareness is probably the first thing when you are talking about prevention. Look at the COVID situation. We have had a lot of problems with the COVID, but one good thing has come up, that the number of kids getting sick has gone down. Why? Because parents are now reluctant at giving them outside food. Unfortunately, they're not going to school, so there is less of an interaction. But also, the kids have learned to wash their hands, which they were not doing before. So many of these things have come in. And just yesterday, there was a patient of mine, and she said, my daughter would get sick at least 2 to 3 times by this time in the winters, and she hasn't gotten sick this time. So, I mean, these are all, we need to make them aware. We have got to, and we can do it with very simple messages. From COVID, we learned that we have given them 4 simple messages. Distance, hand washing, mask, and no undue mixing.
Interaction. So which kind of takes us back to that thing where we don't necessarily have to be spending all our efforts and resources on tertiary strategies, but if we're just looking at primary strategies, that in itself will then have a sort of really positive snowball effect, as it were. But there is something that I was reading about this, and I'd like your opinion on it, is that when we're talking about public health and private health services apparently are not geared towards preventive measures the same way that public institutions are. So
and
what
why
does
should
that
they be?
mean?
Why should they be? A private person is going to earn money out of it.
And they're just
for prevention, you're going to spend. You're not going to earn anything from there. So it is the responsibility of the government. It is the responsibility of a primary care physician as well. Like my teacher, and I'll name him, Professor Billu, and he runs a multi-billion charity. He says the best charity that a physician can give is give 2 minutes extra at each consultation teaching a patient, which I do, and which I wish every pediatrician would do. Because those 2 minutes with the patient, telling them to breastfeed, telling them to wash hands, telling them to be careful at feeding, these make a lot of difference.
And I think this is also probably why the impact of lady health workers going from door to door, and in family planning campaigns, that's why it is effective, because it's the same thing. It's educating the public.
Look at the model of Bangladesh. They used religious leaders for family planning, and it succeeded.
So there's clearly a need to modify existing systems or existing approaches to our own local requirements and our own local challenges as well. So, Dr. Altaf, what are your thoughts on public awareness campaigns and sort of encouraging people to also participate in their own good health? Do you think that's an effective strategy?
I would say that there are 2 things that Dr. Naeem said, which were very good. That when you said that why don't doctors practice preventive medicine, he was right in saying why should doctors practice preventive medicine, which is why you find, because doctors are in the business of curing disease, and that is where they make money. If they don't cure disease, they don't make money. So in some paradoxical sense, it is in the interest of the clinical doctors that people fall sick. The more people fall sick, the more they will do well. Which is why you see this stress on all medical students wanting to become specialist consultants. And which is why you find that the first choice of all medical graduates is to go into surgery or to cardiology or to procedure-based interventions, because that is what generates cost. Because it's a clear-cut system of where the incentives are. For governments, it is very easy. If they start paying doctors who are doing preventive medicine and public health 4 times the amount of money that they pay the surgeons, people like me will become very popular, and then there will be many more medical students will start with public health.
But that's great, actually. I think that's a very easy solution.
Very easy solution. You increase and you invite people who are doing public health at every forum and at every policy making thing. Then the students will see that is where the money and the prestige and the high status is lies, and they will all start that. When I graduated from medical college, I went into obstetrics. I did the obstetrics residency, and I was going to become an obstetrician before I realized that this is not going to solve Pakistan's problems. Even my own teachers and my own parents and my own family used to say, what is the matter with you? You did very well. You got lots of marks in obstetrics. Why are you going into public health? What's wrong with you? So let's set that aside. The other thing is this issue of awareness. This issue of awareness is not something new. You look at what lack of awareness is doing in your immunization program. There is enough research over the past 10 years that highlights that one of the reasons that there is vaccine hesitancy, people refuse to get vaccines to their children, is because they do not know that this vaccine, how prevention works, how useful this vaccine is. They are not aware about the schedule of vaccine. And, these questions are not answered. Creating awareness also is not something that you can do from the pulpit. The Bangladesh example is very nice. Bangladesh used its religious leaders very, very effectively. But Bangladesh also did something more which we ignore. What Bangladesh did was that it decentralized the implementation and policy making and management of its health services. Even when their conditions were so bad in the 90s and the late 80s, they took policy decisions to change the way they organize their health services. So I quite agree that we need to look at the models that are around us, but in the last analysis, you need to develop your own structure and functioning of the health system. So Dr. Naeem is absolutely right that we need to start with the problems that are happening in our country, and we need to build our policies and our systems and our plans and our activities and our programs that cater to those specific needs, and we need to build those into the constraints of our own administrative and regulatory structure.
Clearly, we are faced with a variety of issues, but correct me if I'm wrong, these are also not issues that are unusual in a developing country. I'm sure that a lot of other developing countries face similar problems, clean water or high maternal or infant mortality and endemic disease, if there's hepatitis or there's typhoid or, things like that. But I feel like it's also, for us at least, a matter of effective strategies, because clearly we have people like you and Dr. Altaf and so many other qualified, experienced people, well-versed in policy and practice, who can put together a comprehensive and effective strategy that we can implement. So I suppose at the end of the day, it's also about using what we have in the best way possible. So best practices, in a way.
I think we have to join hands. That's the most important thing.
Yeah.
Clearly, we have public health experts.
Yes.
We have clinicians, and we have clergy, and we have teachers, and we have public opinion leaders. We have to all sit down.
Yeah.
As Dr. Altaf said, it is not just clinical practice which is going to cure people. WASH, which is the sanitation, that is extremely important. Public health works is extremely important. Policy, finances, extremely important. So all these, everybody has to join hands. And wherever it has done well.
Yes.
So I think the gist of the matter is that we should be looking forward to it. We should be looking upwards.
Yeah.
We should be all geared up to these. We can have a health emergency, like we can have an education emergency. Education and then education and health always go hand in hand. You can't just raise your health standards and leave your education behind.
Quite
Both
right.
of these have to go up together.
Yes. So it's a sort of group effort in many different directions. And like Dr. Altaf mentioned, a lot of issues are kind of evergreen ones. So issues of healthy mums and healthy babies and sanitation, these are things that will always be important. So it's not just a temporary.
And we cannot do one thing in an isolated manner. We have had some excellent programs on saving newborn babies.
Yes.
But you know what happened? When I was a student, the neonatal mortality in Pakistan was close to 48 per 1,000 live births.
Right.
You know what it is now? 44. What? Almost the same.
That's not
over a period of 40 years, it hasn't changed. Why? Because the other factors haven't changed. So we have to change the other factors. The maternal nutrition hasn't changed. The maternal health care hasn't been changed. Then the
cultural approaches haven't changed. Where girls are just fed less, who then grow up to have malnourished babies.
And then deliveries in homes. Deliveries are still being, most of the deliveries are being conducted at homes. So, and then it is just one part. Then we are talking of stunted population. We are talking of underweight babies. And so many other things. And then we are talking of illiteracy.
No, absolutely. Thank you so much, Dr. Naeem. Thank you so much, Dr. Altaf, for joining us today. Clearly, this is a big and complicated issue, but I think that it is heartening to know that we have so many qualified and trained and experienced people whose hearts are in the right places, who are still chipping away at that monolith. And, here's to better progress for all of us and, safe mums and happy babies and clean water and all the things that we need to have a healthy and a safe citizenry of this country that we all love very much. Thank you guys for watching. If you're watching this on YouTube, don't forget to like and subscribe, and we will see you next time on the coffee table. Bye now.